Hi, my name's Ian Lawrence. I'm going to drive the slides, and I think Kate's going to do a bit of the overview. I'll do the detail about age and die well, and then we'll sort of open it up for discussion. I'm a GP by background, although I'm no longer in clinical practice. I spend most of my working life trying to improve working relationships, working practices between different health and care sectors. So between my employer, Derbyshire Community Health Services, general practice, hospitals, adult social care in the VCSE sector. Kate, do you want to introduce yourself while I work out how to share?
Morning, everybody. My name's Kate Brown. I'm the director responsible for commissioning community services and also developing community and place-based working for the Integrated Care Board. Just a bit background as well. I've worked in the NHS for over 30 years, all of it in Derbyshire. Very passionate about partnership working and spend most of my working days working with people outside of the NHS in terms of how we're developing, building services, making connections. And so I've been one of the lead partners working on the overall strategy. So we're here today to talk about this key focus area, but I thought it might be helpful to give a bit of an overview of the overall strategy. So if we have the first slide, Ian. Oh.
Yeah, so this is what we're going to talk. So we're going to start with an overview of the whole strategy, and then dive into why age and die well is a key area of focus, and then some of the strategies written in quite technical language. So we'll draw out the couple of pages on age and die well and what that means, what's behind it, and then what's already happening in that area. So this strategy is new, but it's not landing in a vacuum. There's already a lot of work going on in that area, and then a bit at the end about how you can help us and some of the things we quite like you to talk about here and now, and hopefully we'll have a bit of time for discussion. Go on, Kate, now you can start.
Thank you. Are you going to drive the slides in?
Yeah.
Thanks, brilliant. So this is the strategy which, as Beth mentioned, we've worked on with a range of partners, and it's overseen by a new part of the system, which is called the Integrated Care Partnership. But in developing this locally, we wanted to draw together all of the existing, build on and draw together existing strategies, what we know about population health, the work that's going already to integrate how partners work, plans that have been around. On there, the acronym, the JUCD, is Joined Up Care Derbyshire. So a few years ago, even pre-pandemic, we were working much more as integrated organisations rather than separate health, social care, voluntary sector, etc., etc. So we've drawn those together, but we've also tried to be really realistic that this is a challenging environment. We know recovery from COVID still, financial challenges are really significant, and therefore we wanted to make sure that we're developing this with a sense of reality and build on what's possible rather than setting an ideal vision, but that we can't, we're going to struggle to achieve. But we really have a commitment to the belief that by integrating resources, working together differently, connecting and working with communities in different ways, we really can shift the focus onto prevention, early intervention, a focus on outcomes as well as those targets that often drive particularly statutory organisations. We're very driven. Everybody will know A&E targets and weights. There's lots of statutory requirements for social care. So this is about actually thinking about the shared purpose, shared focus that we have. So if the next slide sets some of that out about the fact that we wanted to think about what are we here to do, what can we do better together, thinking about population health, prevention, and thinking about prevention, some of those wider determinants where the roles of district and borough councils, thinking about housing, poverty, etc., really important, as well as service offers, and thinking about those outcomes that we've got in terms of shared purpose. And we'll talk a bit more about what that means in terms of age well, die well later in the presentation. representation. And then we focused on what stops us doing the right things now, what stops us working together effectively. And often it's about the structures we have. So when we say architecture on there, what we're meaning is the ways we make decisions, the way money flows in our systems, how we're working to particular targets, and how we do have, whether we're focusing on those shared purpose, that serving the population in different ways, and then enabling functions and services on there. The thing that emerged for us was the need to focus on our workforce, on the data that we use, on, as I say, things like how we make decisions and commission services. So rather than creating a new set of aspirations, it's more about building on what we've got and making those connections in different ways, and then focusing on particular areas. So the next slide sets out the three sort of life course ambitions that we as a system, could you just have the next one, Ian, had set out a while ago, as I say, when we started to talk about being a joined up care system. So really thinking about that the starting life that children have, and the value of education, access to care, relationships, etc. Then thinking about how we support people to make healthy choices, protected from harm, and then offer good services in terms of health, social care, housing, etc. And then thinking finally about, as people age and eventually die, how we maintain independence and active participation, and how we support people right through life, and focus on what matters to them, as well as the services that are offered. In the strategy, then, we've tried to distill a lot of that previous work into some strategic aims. As I said, you'll hear the words about prevention, early support throughout the strands of work that all of the key areas of focus are looking at. That continued focus on inequalities, which, you know, in some instances have been exacerbated by the experience of COVID. But thinking also about how we make sure we build on the strengths. Individuals have strengths, communities have strengths, we as a system have a lot of strengths, and often we focus on what's the matter with people and fixing them, what the targets are that we're not achieving, and we tried to, in the strategy, really build on what we do well and how we build on that, as well as focusing on the things we're aiming to achieve. And then really fundamentally making sure that the connectivity and alignment across how we work together is giving people a really joined up experience of care, and that we're creating a sustainable system in terms of how we use our resources, particularly as they get more challenging financially. Are we really using the resources we've got in as effective a way as possible? So then the strategy, and the bit we're going to come to and focus on today, focused in on saying, if we want to test and develop those ways of working differently, that governance, that approach to listening to communities and connecting, rather than just have that as a very high level aim, how do we focus in, how do we test that out using those three areas? So having a focus in start well about school readiness, having a focus in the stay well about the three main causes of ill health and early death, and then the focus for today, thinking about how people age and die well, and how we can integrate the care, the support across communities and statutory and voluntary sector services to maintain independence and to really try and support people in the ways that's important to them right until death. And in the point that we focus often on the age well part of this, but the applicability to how we support people, plan for and have a positive death as far as possible is a key part of how we will work, though that's not the particular focus of the conversation today. So I think that then leads into why we've got this as a particular focus. So I'll hand back to Ian.
So why age and die well? So there's a number of reasons. And I'll pick up on each of these bullets as I go through. But the understanding that our population's getting older, as people are getting older and healthcare changes, then the pattern of illness it is evolving, and we need to respond to that. Also the fact that as people move towards the end of their life, the priorities shift from quantity of life, so curing things, saving saving lives, preventing illness, to the quality of life. So actually getting the best out of your final years, days, months of life. And as we move through all of those things as people get older, managing that gets increasingly complex. So our population's getting older. There are lots of graphs that demonstrate this, how that's developed and how it's predicted to develop into the future. This particular graph looks at the old age dependency ratio. So what that means is the proportion of our population who are over retirement age compared to those who are working age. And as you can see, that proportion of older people increases. It is increasing now and is set to increase into the future. One, that's an indication that there are more older people, but the other bit that's a real challenge for society is there's a reduced number proportion of people of working age who are there to look after the older people, but who are also earning and paying taxes in order to pay for that care. That's really important because people's use of health and care services increases as they get older, as they move towards the end of life. Talking about, we're always talking about generalizations here rather than individuals, but aggregated up, the sort of spending on health for an 85-year-old is 5.6 times higher than it would be for a 30-year-old. I think most people would understand some of the reasons why that is. The other sort of challenge in there is that when the NHS was created, most of healthcare was focused around episodic periods of care. So injuries, infectious diseases, the focus was on helping people, then helping them survive and curing them of whatever it was. So your broken leg mends, your pneumonia is treated with antibiotics and gets better. But now that pattern has moved towards people managing illnesses. I've put illnesses in inverted commas there because actually quite often people are living with an illness, a condition, in good health. So high blood pressure is a really good example of that. Lots and lots of people have high blood pressure. They're on regular medication for that. They have regular health checks because of that, but actually they're living healthy, productive lives despite that. And as people get older, they tend to elect conditions. So you might start with high blood pressure, you might add in heart disease or asthma or respiratory disease, let's have a bit of arthritis, and that accelerates older. As that sort of aging process happens, then the way you approach that changes. So the risks and benefits change over time. So, for example, using high blood pressure as an example, again, a 50-year-old who's got high blood pressure and not a lot else will want to take medication to bring their blood pressure down to reduce their risks of heart attacks and strokes in the future. And they'll live perfectly happily on that medication. But once you get to 85 and your body is less robust than it was, and maybe you're starting to get lightheaded and have falls, that same medicine for your blood pressure, you might be choosing actually the problem it's causing in terms of contributing to your falls risk means it's not worth it, versus sort of when you were 50. So that approach changes over time, and that means we need to move from specialism, which is really what you need when you've got an individual condition that you want to really get best to generalism, where you're balancing one treatment, one condition against another to get the optimum mix to for your quality of life and your quantity of life. As you get closer to death, most people transition from focusing on quantity of life to quality of life, and that particularly becomes relevant in your last sort of months and days, when really you don't want to be taking preventative medication at all, because it focuses on getting the staying as comfortable and getting the best out of those the last part of your life. So the focus changes. A good example of sort of where that matters really at the end of life. So most people, when they're fit and healthy, and you say where and how would you like to die, most people say, well, actually I'd like to die at home surrounded by my family and friends. But that does change as you get near to the point where people start to realize quite how scary it is at the end of life, and how much input is needed. Having said that, this graph shows that pretty much half of people die in hospital, and actually, even if dying at home becomes less attractive, being in a different setting, so a hospice or a care home, is probably better than being in hospital. But actually, I suspect the number of people who we could look after at home is greater there. So these graphs, it feels like we ought to be shifting them, but how far? One is very individual, and two, it's not easy to say, well, it should be, because it's so dependent on people's preferences and what happens. I sort of mentioned that complexity gets greater as well. So not only do people tend to collect more health conditions, but actually just living gets harder. People's social networks tend to shrink. Loneliness is a major problem for a lot of people, sort of in the last years of our life, and actually responding to that need is much less around healthcare, and much more to do with care, but also social networks, which actually the voluntary and charity sector and communities are much better at supporting than statutory organisations, but they need to do it in teamwork. So quite often, so my profession, GPs, really important, and increasingly important sort of towards the end of life, people with frailty and complex needs. But actually, they're only a small bit of that sort of support network that people need. And then the other thing that adds to that complexity is that personalisation. Everyone's different. Everyone's got a different set of conditions. Everyone's got a social network. Everyone's got different preferences, likes, priorities, and in the past, we've not been that great at being flexible to people's needs, and actually to get the best outcomes. We're now recognising we need to get much better at that, and already are getting better at it, but there's more we can do. So I'm going to hand back to Kate to do what's in the strategy around ageing and dying well.
So we've thanks, Ian. We've already talked about what's in the overarching strategy and the approach. So this is about ways of working rather than it isn't a strategy that says we will hit this target by a particular point, because we think it's about building ways of working and how we link together, and that definitely is about health, care, and beyond. So as Ian was mentioning there about the role of local communities and of all the partners that support and people work together, and individuals and their families. It does build on what we're doing now. It isn't about lots of new, bright, shiny things. It's about us really building on what we've got, but doing that in an integrated way, and is in line with national priorities. But shifts lots of the national priorities from a health perspective are still very much about recovery and targets and performance. So in our local strategy, we're trying to build, and I'll come on to in a moment, about how we understand then what we're achieving in different ways from those traditional type targets for people, older people, and at the end of life. So on the next slide, I think we've got the fact in the document, and we have written the document, which and we are going to have a sort of a public facing version, but there's a lot of language in there. We've written this for us to drive us and the partners around the table. So we'll talk about things like simplification, and what we mean is that it's easier to find your way into something. There isn't a wrong door if you try and access a service that connects you into the range of other service, rather than trying to have to find the right route in, which people tell us can be so frustrating and difficult. There's other things about how we integrate the data that we use, so that there's single records of care. And again, there can be challenges around how we do that. Not these things aren't easy and quick to resolve, but having a focus and a commitment to try and work through that, so that people aren't having to tell their story multiple times, and that things integrate. These have been ambitions that we've had over many years. And I think we wanted to use this strategy to really focus in on those and test them even further. We've talked about teamwork here, and about just how we practically do that. Again, these sorts of phrases about we'll do it in integrated ways, we'll team up. What do we mean by that, and what's getting in the way? How do we work through those things, and how do we build? It's not always about sort of processes and protocols and things that we can write down. It's about building trust, giving people space to develop how they work, about having the opportunity to work in areas together. So when we say co-location, what we're meaning is about just being in the same building, having those same spaces, and those things can practically be very challenging, but are the things that really can unlock how people can work together in really different ways. And then finally, there's something about how we know that we're making progress. So we're trying to develop a range. We've got lots of measures and metrics and data across all of our services, health, social care, and a lot of data in the voluntary sector. How do we bring that together so that we can understand where we're making progress, and think about that in terms of whether we are improving health and well-being, people's life and quality of life is improving, people living independently, more independently and for longer. Are the services that people experience good? Are they responsive? Do they get them quickly? Do they meet the need? And are we overall, some of those longer term targets and outcomes around health status, can we see that the dials are turning on some of those key measures and metrics? And are we improving the quality of death? And are we, in terms of where people die and the experience that their families have? And then we do have to focus again on that, though, on value and sustainability. So have we got enough services? We know fundamentally at the moment there's a lot of capacity constraints in the system, meaning that we haven't got the care packages available, we haven't got the bedded care available, people can't access general practice when they need it for all sorts of things. We know that those are challenges. So how do we, in this key area of focus, look at what that means, and how we can work together to address those problems, and then for this to understand how we're making improvements. And we think that the workforce is really fundamental to this. If we're making sure that we're planning our workforce together, that we're improving the health and well-being of people, formal and informal, in terms of who's supporting them, that's better care, better support for everybody. So making sure we're focusing attention as well on that element of how we're improving services. So we're tasking ourselves with how will we know, and it's really, if there's chance in the questions for you to tell us how we will know that we're making a difference. And in an overall way for the strategy, we're also looking at how we might evaluate that in different ways, from traditional sort of measures and metrics, to try and say, are we improving things? So it's really going to be really important to hear from people, carers, from staff, from individuals, as well as, and taking that alongside the normal measures that we use to show whether we're making improvements over time in this sort of approach that we're setting out. Thanks, Ian.
So what's already happening? Quite a lot, as it turns out. So we've got a big sort of community transformation program called Team Up, which at the moment in its current form is focused around people who where we need to go to their home rather than they come to us. So that's a good indication of someone who's along that level of complexity. And we're doing that. So there's a recognition in doing that, is that we've already got thousands of people in Derbyshire who work in services that go into people's homes, but quite often they're disconnected in terms of communication routes and knowing what each other are doing. So we're really trying to work out how to bring those together into a single team, and we're making some really good progress on that. Just to give a sort of an example of the scale of that work, so don't worry too much about the detail on this slide. It's really just to give an example of the breadth of things that we're having to work through in order to get that to happen. So so in the lozenge on the left, it's some of the actual services that are forming part of that. The bit in the middle are those bits of enabler work, so making sure the computers all work, that we've got workforce planning, that people's HR processes are there, and then on the right hand lozenge are some of the other pathways, bits of the system that those teams need to engage and work with. I'm not going to go into any more detail than that, because actually we'd quite like to leave half an hour to actually have a conversation. So I'm going to stop talking and sort of pause for questions. But as well as questions to us, we've got a question to you, really. So if we're thinking about team working in its broader sense, that's not just sort of statutory services, that brings in patients, service users, their carers, their families, their loved ones, but also communities, the voluntary and charity sector, etc. And actually, we're not great at it, but are really trying to improve our skills in that area. But the other thing is, it gets very big and complex very quickly, because there are so many organisations, community groups, etc. So there's over 2,000 sort of within Derbyshire that we're aware of. So really is a bit of a question as to how can we make that easier? How can we make some sense of that? How can we make that much more meaningful? So I think that's pretty much me. I'll stop sharing and see where we go. Thank you very much.
Thank you, Kate and Ian. If anybody has any questions, if you'd like to raise your hand, or you could put questions in the chat box as well. Chloe, do we have any questions in the chat box to start with?
Yes, we've got one to start with. So Seema has said, I'd be interested in knowing if all specialities have been involved in the creation of this strategy to ensure effective re-enablement, e.g. use of allied health professionals in all elements of the pathway.
Really good question. Could I say that everyone has been involved? I would say probably not. But a lot of people have, and in developing it, we've used a lot of insight that's already in the system. So sort of insight from events like these, but also events like these that we've done with staff. I'm going to shut up because Kate's been much more involved in developing the strategy than me, so she might have a more articulate answer.
well, I'm not sure if it'd be more particular, but I think my response would be, I think this is, it isn't like what we're that what's being recommended is a specific pathway that says this is how this would happen, which would obviously involve input from all of the relevant professionals. This is about framing a shared ambition and about creating mechanisms that mean teams can then come together and work on those pathways. And similarly, there's lots of transformation work happening in social care and lots of changes happening there. So this strategy said we need to connect those pieces of work. We need to enable teams to work together and design the pathways. We need to try and do once what we should do once in terms of the things that have to be clear protocols, but we should allow local adaptations of those. So I don't think this is saying this is a blueprint for a pathway and therefore needs to have had everybody. It's about framing the way we work as a system. So I anticipate that all the relevant people are involved in the specific detail of delivery, and the strategy itself has been informed by the knowledge that that's important, not by the specifics about individual specialties, professionals. But if that makes sense, thank you.
Wonderful, thanks, Kate. I saw a couple of other questions pop up there. Chloe, do you want to come to them and then we'll go over to you, Anne, after those ones?
Yeah, definitely. So Carol has asked, so I know the Aging Well team as part of Team Up are involved in supporting both older people and people with learning disabilities in care homes. Will Team Up include people with learning disabilities too?
I think I'll take that one, Kate. So at the moment, Team Up is focused on people in their own homes, and we would include care homes in that, and so that would include anyone living in a care home for whatever reason. So that would include learning disabilities. I think in where we're going next in expanding the Team Up ethos out, we're going to focus on anyone who needs a really multidisciplinary, multi-agency approach to their care, their support. So that would very clearly include people with learning disabilities, but there are lots of other populations that would include. So asylum seekers is a good one, people who are homeless, people with severe mental illness. So all of those sort of cohorts of people who've got complex needs, really. So yes, is the shorter answer.
Okay, wonderful. Okay, Anne, shall we come to you?
Thank you very much. I happen to be in the, well, I might as well tell you, I'm 92. So I happen to be an elected governor for DCHS. I also happen to be almost totally deaf. So as a person, I have a lot of experience of not only my own getting older, but my own parents, my husband, and nearly all my friends around me. I don't think you're taking quite enough notice of what the older people actually themselves think. That's one reason why I've continued with being a governor. I'm now in my third term as governor, and over time I developed an organization called Deaf and Hearing Support, in fact 30 years ago. And since 1 in 6 of the population of this area has got deaf problems, I think it needs to be given a lot more attention, because deafness is totally isolating. If you are really deaf, you can't join in almost anything. I love going to the theatre, but it's hopeless. I can't hear at the theatre these days. The same with family conversation. You don't get joined in because you can't hear. And yet deafness is something that is not actually dealt with by DCHS. They employ somebody else to bring it in. Now that strikes me as being a very retrograde step. you really do need to be able to hear what people are saying to you. If you can't, you are very much by yourself. I know I have a special bell on my door and my telephone. Otherwise, I can't cope solo. I don't think unless you actually are deaf or you have family members who are deaf, you realize just what the effect of that is. And there's a devil of a lot of the population have got hearing problems. I like to join in on these video chats, but very often people don't know how to use the microphone on their videos. You, sir, were doing beautifully, and so were you. I could hear you both. But a lot of other people tend to you can't hear what they're saying. So though it gets away with the problem of not being, I can hear you, but I can't hear what you're saying. And this seems to be something that these days nobody takes any notice about. The way people speak, they tend not to face people when they talk to you. So though they may be perfectly clear to themselves, they certainly aren't clear to anybody else. And
okay, thanks, Anne. I'll take that over to Ian and Kate just to get a response for you.
I'm sorry, I couldn't understand what you said.
I'll just pass it over to Kate and Ian just to get a response to your comment.
Yes, well, you see, this.
Do you want to respond, Kate, or shall I? I'm happy to.
Well, if you're happy to, I think it's for my comment would be about thank you for the comment and noted really in terms of the challenges. And I think that your opening statement about we need to listen more to people directly affected is really important and something we want to build into how we develop delivery of this strategy. So that's noted. But Ian, if you've got a specific comment.
I do. So I think it talks very much to that personalisation element. So there are lots of issues that people have that make it difficult to engage. So deafness is a really great example. Being blind is another. Learning disabilities has been mentioned. There are all sorts that you can then get into poverty, cultural differences, all of those things. So being mindful and responsive to everybody's individual circumstances is really important. But also that's why it's so important for us to interact with communities in the voluntary sector, because only through bringing in people who've got lived experience of those things can we really respond to it. Because trying to do that from a more privileged, less experienced position, you can really get it wrong. And I think we have done in the past. I think we're getting much better at it. But again, we've got a lot of work to do and a long way to go to really get good at it.
Wonderful, thank you, Ian. I'll just nip over to Chloe to see if there's. I know the chat's been quite busy, so we've got some questions in there.
Yes, we have a few. So one from Lois, and I'll read it out. And if I'm not doing the question justice, Lois, you can feel free to interrupt me. But just I'd like to ask a question about where a preventative approach around financial well-being is reflected in this approach, recognising that there's significant existing investment across direct, delivered and commissioned services and some excellent work done, but the value of it in terms of individual well-being and preventing future service demand is considerable.
I've noted that she said at the end of there, Chloe, she could expand on the question if that's helpful. I wonder if it would be good if Lois is happy to come in and just draw that out in terms of a specific be helpful.
Thank you. Thanks, Kate. Sorry, I was typing and thinking I could type an essay here, but I don't really want to. So I think obviously my work, I'm just to kind of declare my interest really. I'm public health lead at the County Council for financial inclusion. So we work with directly delivered advice services from the council perspective, but also from commission services from citizens advice. So for example, there's a commission service in GP practices for advisory services. We've got everybody that's discharged from hospital and notified social care is offered a benefit check at that point because of their changing life circumstances. And we recognise the value of that work, but also there's so much more that could be done. And the recent report from Policy and Practice has said that they reckon there's £19 billion of social security benefits across the country that's not claimed. So we do a lot of work through the life course with all sorts of different people. And I just would like to perhaps see in either Team Up or in some of the other work that's going on a bit more recognition about the kind of underpinning financial well-being. If we can get somebody who's living on £280 a week an additional £50, 100, £120 a week, then they will keep the heating on and they will eat better, and all of those kind of underlying things that mean that they will actually be more resilient to any knocks that come to their health, but also their kind of general underlying well-being will be better. So that was just a reflection, and I'll pass that back to you.
I'm happy to come in. I think we need to make a link, Lois, because I think what you've just said there really gets to the heart of the ambition about all people who come into contact with people going, what about, could I connect them through? We've had conversations previously thinking about some of the housing things where you've got care providers going into houses where they might spot that the house is cold, might need a new boiler. How do they easily, as a practitioner, how do they easily, without them having to be skilled in all of that, how do they get that person connected to where they might help? So seeing all of our services as a web, you know, you touch one bit, you're in touch with the rest of it, because we often silo work, we don't connect, we make it very complicated for people and ourselves as professionals to get people the right support they need. So I think any ways with your expertise that you could help us to get that embedded and make it easier to connect people to that offer that's there would be fabulous. So that's an example of the connections that this strategy and approach wants to make and build on, and just then keep identifying more and connect and network out. So yeah, definitely pick up with you afterwards. And similarly, I've made in the contact, and Melanie, you made an offer as well, so thank you for that.
Yeah, so I would add that needs doing not just at system level here, but at local levels through the local place alliances. All of them now have sort of groups of workers whose role it is to make connections in the system. So the social prescribing link workers, local area coordinators, care coordinators, making sure you're all aware of each other in a particular local area is a really important bit to this, and actually that's some of the conversation we need to have and build and drive in local places, and having those relationships and just knowing what's there and about is half the battle, really, isn't it?
No, thank you, Kate and Ian, and a really good challenge there as well. It's a really good connection made. Judith, we're going to come to
you. Yes, I'm the trustee and treasurer for Chapel on the Frith Mobile Physiotherapy Service, which is a small charity based in the High Peak. We employ one senior physiotherapist and have recently increased his hours from 3 days a week to full-time because of the huge increase in demand. I'd like to echo what Anne said first of all. I accept that an ageing population presents a challenge, but I don't think older people should be seen as a challenge. 100% of our committee are older people, and probably 100% of our supporters, people who bake cakes, make coffee, sing in choirs, put on events for us to raise the £2,000 a month that we need to keep this service going. Only a third of our funding comes from the NHS. What we're finding as a service, the physiotherapist accepts referrals from local GP practices and visits people at home. And because they're waiting so long for things like hip and knee replacements and are in pain, they've had no mobility for a long time, and after their operation, there's a huge amount of time needed to get these people mobile again, and a large amount of work needed. We do a lot of work around signposting people who've become socially isolated. We aim to keep people independent in their own homes for as long as possible. So on top of that, we've worked with Derbyshire HUK and trained around falls prevention. So as a committee, we stand on market stalls and give out information about falls prevention. What I want from your service is to facilitate the fantastic work that we're already doing. There's a lot of bureaucracy involved in contracting with the NHS. I spent most of yesterday filling in the data security questionnaire, which is something like 40 pages long. And I appreciate the need for data security when I'm dealing with confidential patient information and the need to show what secure systems we're using. But some sort of support in dealing with all these contractual obligations would be very much appreciated to free up someone like me as an older person who's not very tech literate to get on with the work that I do really, really well in our local community.
Thank you, Judith. I'll pass this over to Ian and Kate.
Oh, I'm dead keen to jump in. So there's loads in that, Judith. So one, what a great example of there's loads of good work that we need to build on and encourage. So I think that's great. The bit around older people are part of the solution rather than couldn't agree more. And actually, in terms of tackling some of those real challenges around social isolation, etc., volunteering is a great, if you want to use the word, treatment for some of those things. So the more of that sort of work that we can do, the better. And that's there's quite a lot of talk about strengths based and building on strengths, so that's absolutely the sort of things that we're talking on. And then I'll just want to draw out and capture that that idea for how we can make it easier. Maybe we can't get rid of the bureaucracy, but what we almost certainly can do is find ways to help people with it and through it. So I'd really like to capture that little nugget. Thank you.
Thank you, Ian. Chloe, you can go back to the chat. Is there any questions there?
Yeah, there's lots of great comments, and there's kind of, I think, 3 questions. So what are the challenges you see in getting teams, services and providers coming together and having a system approach?
That's a big question.
Yeah.
do you want to have a go, Kate, or shall I dive in again?
It's a great question. I'll start with, I think there are lots and lots of challenges, and it's what probably Ian and I spend a lot of our time focusing on, and how we identify those and unlock them. That there's massive challenges about time, people's time to work together and think differently, and headspace to do that. There's often competing protocols and bureaucracies, and part of our job is identifying where they exist and what we could do differently. So sometimes the finances and the targets and ambitions in different organisations drive people to behave in different ways. So all of this work is around identifying what those sorts of things are and then working through them. And they're never simple, because if they're simple, people would just deal with them. But it's often that you can't deal with them at that local level. You do need that system, some big system things to change. So we're continually trying to surface those, work through them, and just try and get that alignment of opportunity. So I think some of those are some of the things that come to my mind, but Ian's probably even closer to it and will have an even more informed list.
yeah, so working through that is my job, I suppose. So just thinking about the financial bit, so if you think about the 3 sectors, the financial drivers are completely different. So the NHS not funded well enough, but accessing NHS services, it's free at the point of delivery, so we don't need to worry about billing, charging people. Adult social care, not free at the point of delivery, most people having to pay for adult social care input. And then you get into the VCSE sector, where the financial challenges are always, okay, what's the next 6 months, what's the next 6 months, where do we get our funding from? So you've already got a real breadth and disparity in the financial drivers, different terms and conditions in those different sectors for people doing really similar jobs is another challenge. We've already mentioned that the challenges of sharing data and being able to see records between different bits of the system, really difficult, because there's real benefits in sharing, but there are real risks in sharing as well. So working through all of that is really challenging. And then the change in sort of political direction from using the market forces to try and drive efficiency and improvement towards the newer world of collaboration. Actually, everything's set up to drive competition, and everything's all about driving individual organisations' stability and improvement. And actually, what the changing that culture to one of collaboration and is. Yeah, it's not easy, because we've got a generation of behaviours in people's jobs that need changing, and they are changing quite rapidly. But blimey, it's hard work.
Wonderful, thanks, Ian. Claire, I think we've got time for one more question.
Yep, so Nick has asked, what plans are there for the reciprocal sharing of appropriate data/intelligence across the system, e.g. with the VCSE sector? And he appreciates that there's significant challenge in that.
I was just starting to type a reply to that. My reply was going to say we're not there yet, Nick, and our approach is, I think initially it's likely to be working through the VCSE Alliance as a way to try and understand what's possible, and it is the Alliance that's been flagging about there's a rich source of data, particularly in terms of a way of identifying need, because of the people coming through the voluntary sector that then have got needs that can't be met, and that's a really useful source of information. So how might we share some of that? So we've been including some of the work we're doing to try and get to the detail of this and what might be possible. We try always to have colleagues present from the voluntary sector to challenge our thinking, but in terms of formal data sharing, I think we're on the foothills of that, but I think the contact would likely to be through the VCSE Alliance. But again, as I've put in response to other questions, if there's ideas and suggestions and ways we can cut through some of that, then please suggest those and help us to work through that. So it is a really difficult area, but it's something that we've definitely got as an ambition, because it's really important that we use all the data we've got to best design, plan, deliver, serve the population. Thank you.
Yeah, and I'd say I would add that data is a major focus within the NHS, because actually the developments in data science around artificial intelligence, all of those things are starting to bear on the NHS and wider, and they all need data to drive them, and there are risks and benefits to all of them. It's not really a health example, but that example of facial recognition, that's all about data and data sharing. Most people like facial recognition when it helps them log into their phone, but most people wouldn't want it used on a security camera in the street that can follow you round, which doesn't happen, I don't believe, but is possible. So there are some real fundamental ethical questions around how we share and use data, which are not simple to unpick. And that's driving some of the reticence for sharing, I think.
Thank you, Ian. Thank you, Kate. I'm going to start drawing the meeting to a close. I'm just conscious of the time, but I just want to just give reassurance. Anybody who's left a question in the chat box, we will respond to you. The next stage after here is this video will be uploaded to that engagement platform, and Chloe can put a link in the chat box for people as well. But we will also be sending it out on the email over the next couple of days. So this video will be uploaded along with the one that we did the other evening, which also has a British Sign Language interpreter on on there as well. On there's also these presentations. There'll be areas so you can carry on with feedback or questions, and there'll also be updates about what the next stages are as this particular key area develops as well. So please carry on getting involved, carry on with your comments. Everything will be collated into one document as well, so all the questions that have been asked today with the responses, any comments, and they'll be fed in as this area develops as well. So I just want to, again, thanks everybody for coming today. Thank you, Kate and Ian, for your time as well, and thank you, Chloe, as well. So everybody have a lovely day, and hopefully I'll see you either on the tonight session or on the Monday session for Stay Well as well. Okay, thank you. Bye, everybody.
Bye.
Thank you. Bye.
Bye. Thank you.